Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. On this episode, we speak with Dr. Lauren Roberts, a PGY-4 Emergency Medicine Resident at the University of Saskatchewan, to separate fact from fiction when it comes to the effects of anesthetic medications on breast milk. We also talk about resources that are publicly available to breastfeeding parents that can help give more insight into how certain medications interact with breast milk. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come take a break with our host, Anesthesia PGY-4 Alex Pellerin, and a multitude of brilliant and insightful guests as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Welcome to our next episode of Airway Breathing Conversation. Thank you for tuning in. We have a very, very exciting episode here today. We have, of course, as always, Dr. Seb Turcott, one of the anesthesia residents. And then we have Dr. Lauren Roberts.
Hello.
She's an emergency medicine resident in her fourth year. Dr. Roberts and I are trauma bonded because we did ICU together.
For sure. And during a rough time in the
It was a rough
world.
time in the world. Yes.
Yeah.
Many sick patients, many respiratory concerns.
Correct. Yeah.
Yeah.
Little pandemic that you may have heard of.
Yeah. Oh my gosh. So cash.
Yeah, so cash.
May or may not have heard about this crazy pandemic. So Dr. Lauren has graciously offered to come onto the podcast to talk about a really great topic, which is breastfeeding during and after some sort of anesthetic procedure.
Yeah, totally.
Or procedure requiring anesthesia, I should say.
Yes, yeah. And just, some kind of thoughts around breastfeeding in general and how it might relate to the world of anesthesia. I feel like I have like a weird passion for this topic because when I started breastfeeding as a mom, I think people sort of assumed like, oh, you're a doctor, you probably know like all about breastfeeding and medicine, and it was even things like, oh, I want to take Tylenol, like, can I? And I feel like in med school and residency, like, not mentioned. I don't even know if the word like breastfeeding was mentioned in my medical school curriculum like one time or like and in Emerge certainly we see patients sometimes like that come in with like breastfeeding related complaints like mastitis, and the first question they ask whenever we prescribe them anything is like, is this safe to take while I'm breastfeeding? And then just kind of through like talking to other moms and just being in the medical world, you just see all these, it's like it's relatively common, and the obviously peripartum and postpartum period is a time in a otherwise young and healthy woman's life that they actually may have more procedures and things like that just because of all the pregnancy related complications, but just in general. And so I think it's important to talk about. And I think in addition to being under-recognized from a medical perspective, the whole breastfeeding kind of has a lot of moral and sort of ethical considerations. Yes. Like people feel very strongly, and there's a lot of, women who feel like they're not good enough because they want to breastfeed and they can't breastfeed, or they feel like an inferior mother. There's so much like tied up in the like feeding of your baby. It's similar to the pregnancy thing where it's like your body is failing you. And I think there's just a lot that we can do as physicians to support women meeting their breastfeeding goals, or I should say feeding parents, like meeting their goals, whatever those are. So that can be inclusive of formula feeding, or, some women may have no interest in breastfeeding, and that's also totally fine and acceptable, and absolutely like feeding your baby the whatever way you want to is awesome. But I think women often have breastfeeding goals that are not met because of some of the lack of medical understanding around it. So that's why I wanted to come and chat about this.
Amazing.
Yeah. Should I talk about the like general anesthetic considerations first, or do you have anything specific you want to hear about?
Yeah, well, actually, I was just going to tell you that when I was in nursing school, I had to take a breastfeeding certification course.
Oh.
And I actually learned a ton.
Yeah, that's amazing.
And then I got a little certificate, And then I felt really embarrassed never having breastfed myself, teaching people how to breastfeed.
Yeah.
Which
yeah.
is like, I think its own really complicated thing.
Totally.
And it's really difficult. And then there was that big thing when I was in nursing school anyways, this was like in the mid 2010s.
Yeah.
When the Breast is Best campaign came out.
Yes.
And I think it was very alienating for
sure.
people, because I think probably the best thing, like you kind of alluded to, is just that like feeding your baby is best. However you choose to do it is like the best way.
And it's an interesting thing because I think the intentions behind the baby first hospitals and promoting of breastfeeding are pure in their intention. So I think I can't remember the exact numbers, but I've read some studies that it's close to 90% of birthing parents like want to breastfeed their children, and the American Academy of Pediatrics, Canadian Pediatric Society, all of those like big bodies, they recommend breastfeeding for like 6 months exclusively, and then like up to 2 years, depending on like the feeding duo's wants and wishes. But the number that actually make it that far is quite a bit lower. So exclusive breastfeeding to 6 months is somewhere in the like 20 to 30%, and breastfeeding at all at 6 months is less than 50%. So, I think that I think the thought was, there's these women, birthing parents that want to breastfeed their kids and they're not meeting their goals because only 40% are doing it at, this 12 and the 6 and 12 month mark. And so what can we do to support it? We're going to like really push it as the best thing you can do for your baby. But then in doing that, I think we just also made it seem like if you couldn't exclusively breastfeed, then why breastfeed at all? When really like there's so 100%. Many benefits to even if you're giving your child, an ounce or two a day, that's great. And as someone who's currently working and pumping for my baby, like it is not maybe as bad as being pregnant, depending on your pregnancy, but it's, it's like time. It's you wake up feeling engorged. I've had mastitis several times. Like it's a lot. It can be a lot, and I think it could be like that for anyone. And there's a lot of concern. So I think if we can have just a tiny bit of knowledge about if you have a patient that's coming to you that is lactating, just to have just in the back of your head. And I have some resources I can share too that are ones like an app, and others are just websites that you can quickly Google things. Cause like, I can't remember like what the bioavailability in breast milk for like every drug I prescribe is, but there's so many good resources. And I think in 2023, when we can look these things up easily, then the first one we had kind of talked about was like in that like initial like in the labor and delivery phase, in that like intrapartum phase, there's some people will talk about, or there's like some stuff on the internet about not getting epidurals or not getting analgesia in labor because there's been studies in the past that have shown this association between epidural analgesia and poor outcomes with breastfeeding. And the one paper that I found that's kind of this debunked one was saying that the women who had high doses of analgesia reported like 3 times as much difficulty breathing in the first 6 hours postpartum as women who didn't have an epidural. But all of these studies are like retrospective, observational, biased in that like someone's like standing there watching you being like, you had an epidural, are you having trouble breastfeeding? So all of the more recent studies and like, again, in general, there's like a huge paucity of literature around this, but there really is no difference. And there's, maybe a few things about like fluid administration in labor leading to like more engorgement and more difficulty with latch. But I think if you're working, if you're in a hospital or a setting where or even at your home and you have a midwife lactation consultant or a nurse that's done it, like even if you haven't done it yourself, like all of those things are should be overcome. And certainly it shouldn't be a reason to not offer epidural analgesia to your patients. So like, I think hopefully if you're working in obstetrics and women ask you that question, I think certainly to sort of debunk that one and just say like, the outcomes are varied and there's not really like a clear causal relationship.
Right.
The one kind of like blog post I was reading about this said that like, okay, is it actually that women who have had epidurals are less likely to have success breastfeeding, or is it that like there's a huge like confounder here, which is that if you're having any intervention in birth, you may have had a more difficult labor, maybe you're prolonged labor, maybe you're an induction, and like those things are going to cause problems. It's not probably the epidural itself, right? And there's many women who have epidural analgesia that breastfeed totally fine. So yeah, that's like the first one. And I think there's so much, again, like cultural stigma around labor and
Yes.
analgesia in labor. I don't know if you guys see that when you're working as much, or if people
think
come in
it's-
with a plan.
I think because in anesthesia residency, we do a rotation on the obstetrics ward and assist with delivery and assessment of women to determine whether or not they're in pregnancy, to really like know what our obstetrics colleagues do, and so that we understand what they do when we provide obstetrical anesthesia. But other than, I think, birth plans that I saw where people were very specific about what they wanted or didn't want.
Yeah.
Now, when we get called as anesthesia residents at night or during the day, it's because someone has already expressed interest and wants an epidural.
Right. They're not calling you to like talk
They've
through
already
it.
been screened. Yeah,
Yeah.
they've already
Yeah.
requested one, and so that's why they're calling us.
Yeah.
But this is a lot of information that I didn't know.
Yeah.
That I imagine I will be asked about in the future, though, because sometimes patients still
Absolutely.
have. Sometimes we get called and patients just have questions about an epidural before they actually want to go through with one or
Right.
not.
Yeah.
And I don't think I've been asked specifically about breastfeeding, but it certainly will come up, I'm sure, in the future. So.
Yeah. And
Yeah, me
obviously,
too. I don't think I've been asked specifically, but
personal factors can affect it, right? Maybe if you've had one, like, again, I'm in some like mom groups, which are like the depths of the internet. Like there's like the dark web and then there's mom groups. Like they're almost the same, I think. And yeah, there's just people have these like super strong opinions that, as someone in medicine, sometimes you're like, I don't know, it's so anecdotal, right?
Yes.
I had an induction and therefore that's why I needed an epidural. And therefore that's why I had problems breastfeeding. Whereas you have to meet someone else who like had induction but didn't need or didn't choose an epidural and then had no problem and people just really glue onto those things as facts when they've had personal lived experience or even a friend where they're like, oh, but I had a friend who had this. And sometimes I think like this pendulum of how much we're medicalizing childbirth has swung in so many directions. Like 40 years ago we were like knocking women out because it was like, oh no, women can't handle this,
right, like doing a
thing,
full
general
general
anesthetic,
yeah, like
right?
no labor,
and then sometimes the pendulum swings the other way, like let's have like free births in the ocean. And like the right answer is probably somewhere in the middle, and also so dependent on personal factors. But yeah, I just think there's so much like there's so many hot takes around labor delivery. So I just like hope that that's one thing that we can just be like, okay, like choose what's right for you and right for your labor situation. And then don't really worry about the breastfeeding aspect. So yeah, maybe you'll get asked, maybe you won't. But honestly, I didn't really know that either. Yeah, you do. The other thing you do hear about is like, if you're giving lots of fluids and you're cesarean or something, that the babies sometimes come out like bigger, and then therefore they lose a little bit more weight as they like lose that water weight, and then their weight gain or their weight loss looks worse than it probably actually is. And so then like providers at the hospital usually are like, oh, we need to supplement your breast milk because they've lost too much weight. And it's like, is that real or not? Who knows? And I'm certainly like, this is why we need an obstetrics resident to come tell us, like, is this a real thing?
Which we tried to do.
We did
try to have an obstetrics resident come join us. Lauren did a very good job at that. Unfortunately, they were on call tonight,
Yes,
which happens a lot when we try to get residents to come on. Because we all have
everybody's schedules
duties.
are a bit
Duties,
different.
for
we all
sure.
have like these jobs we have to do, plus have a like good personal life outside of medicine.
Yeah.
So, but we always have to talk to our obstetrical colleagues.
For sure.
On the intrapartum side of things, Lauren, sometimes women have to go for an urgency section or something like that. Is there anything in your research that you found in terms of medications given during a C-section that might affect breastfeeding a little bit?
So I think that and this kind of actually will probably just go into the part about kind of general anesthetic, because from my understanding, and I don't do general anesthetics, but from what I understand, if you were giving a general anesthetic for a C-section, it wouldn't be procedurally that different from when you're doing a general anesthetic for like a cholecystectomy or something like that. So we can totally talk about that. So for like undergoing a general anesthetic, the American Academy of Breastfeeding Medicine, as well as the I think American Anesthesia Society. They both have statements that essentially if you have you have to, when you're thinking about like, can this breastfeeding dyad resume breastfeeding, or like, do they need to pause, or do they need to pump and dump? Like the questions that you need to ask yourself just generally, right? Or does this drug even get into the breast milk? If it is in the breast milk, is it orally bioavailable to the child, like to the infant? And then what's this baby like? Is this like a 24-weeker that's like, at super high risk for all of the things and like having really poor growth and needs fortified milk and all of that stuff? Or is this a term growing well, eating solids, 9-month-old, still breastfeeding? And like, obviously there's a massive range in between that. But I think specifically when we talk about a lot of this stuff, as far as like anesthesia and the mom, generally I'm talking about healthy term infants who are like growing well for wherever they are. So gaining in that like 20 to 30 grams a day in the first little bit. And then obviously the growth rate slows down after that. So yeah, if you're generally thinking about like your term infant that's generally well, if they're immunocompromised, if there's other stuff going on, obviously like some of these you're going to be a bit more careful. And then the last thing, of course, is like, can this drug be timed? And probably not for like an emergency general anesthetic for a cesarean, but like if this is like a procedure or some sort of regional anesthetic, like is there a way to time this that like it's going to interrupt the feeding the least? So if you can think about all those things, that both of those statements say, if you are a mom, a parent of a healthy term infant, pretty much as soon as you can hold your baby, you can feed your baby. And the reason they talk about that is that like when you have resumption of your normal mentation, that's like your guys' hallmark that your plasma concentration of your drugs is like low. And the plasma concentration of drugs is usually the concentration of the drug in the breast milk. So it's the same with, I was thrilled to learn this about like the alcohol pump and dump thing is old news because if you're drinking when you're pregnant, then the plasma like blood alcohol concentration is the baby's blood alcohol, right? But when you're breastfeeding, the plasma blood alcohol is the same as the breast milk alcohol level. So if your plasma is like 0.08, the breast milk is 0.08, like that's so low. So for reference, like orange juice, the concentration is like 1.0. I can't remember the units, if it's like whatever decaliters per mil. So if you were at the level of like blood alcohol content where you would be illegal for driving, your breast milk would have less alcohol in it than orange juice. So it's like you have to be seriously obtunded for your breast milk to have any, and you can buy those like strips where you can test your breast milk to see if there's alcohol in it. And like they will be positive because there is alcohol.
Right, because it's just like a positive or negative test.
Exactly. It's not like a concentration. And so like that's why this, like if you can hold your baby, you can feed your baby. Like if you're of right enough mind to feel like safe holding your baby in a chair is probably fine. So similar theory with these like general anesthetic drugs and specifically the ones that you guys, again, from my knowledge, use all the time. So like your general anesthetic agents, like your propofol and all of your halogenated gases are very, very safe. For benzos like midazolam, lorazepam, very safe. They do make a note about diazepam specifically just because of its like longer half-life. And it does, like there's this RID number, which is the relative infant dose. So they talk about this 10% as like anything that's less than 10% is generally considered safe. It's like the weight adjusted of the maternal dose. And for diazepam, I guess it can get up to 40% just due to that, like it stays in the plasma. It's like highly plasma concentrated. So yes, but you have other benzos to choose from.
Nice short acting things.
And yeah, exactly. And then for your kind of neuromuscular blockading agents, really all of those are the same, mostly because they have like very low lipid solubility and they're also not very orally bioavailable. Like I don't actually know if you drink rock, would
anything happen?
Would anything happen? Like I don't know in an adult, but apparently they just have like quite poor, like you'd have to drink so much. And again, that RID value is like quite low for them.
Very low, yeah.
And then like the people always ask about opioids, oftentimes too, because there's mothers that are like having, issues with substance use. And they talk about in that setting, like the substance abuse setting, if someone's like well controlled on methadone, like those, we should still encourage those mothers to breastfeed. There's like lots of good evidence and like there isn't, the infants don't seem to have issues with the like neonatal abstinence syndrome. But again, that's talking about like the kind of like stable mother on methadone. If you have a mother that doesn't have issues with opioid dependence, like a lot of we have options for our like intravenous opioids that are like very short acting and fast acting. So like all your fentanyls, all the eels, they're like safe. They're low in breast milk. They have low oral bioavailability. And again, they're like fast acting. The one that they do talk about is like, and I'm like, who cares? Because I don't like using these drugs in adults either. Is like your codeine and tramadol because of the CYP2D2 metabolism that is, like the amount of active metabolite can vary so much person to person, baby to baby. And there's been lots of studies that show some kind of like, infant drowsiness.
Like for the like hypermetabolizers.
Yeah, exactly. And the thing is, but like I'm like, well, I don't care because I don't think we should be using those drugs in adults either. So it's like not a problem. So I think like generally, and then the other analgesics, like they talk about like if it would be safe to give that analgesic to that child, it's safe for the mom to use. So like Tylenol, we literally give Tylenol to kids all the time. So like, take your max dose Tylenol as much as you want. We avoid ASA for the same reason we avoid giving ASA to kids, and it's like for the Rise syndrome. And then NSAIDs are safe unless the baby has a ductal dependent lesion. So it's just like you can just use the same principles. Like imagine you are giving that medicine straight to the baby. But like really you just like when I looked through all this and I was just going to look because I had a thing here where I had the actual absolute contraindications. So it's like maternal HIV infection. And it's not even a true like total contraindication. It's just that in North America we have like great access to safe formula, and so it's like just preferentially use that. Whereas if you were in like a place that maybe didn't have that, then it's like they still encourage the moms to breastfeed because the baby needs fed. And then for like meds, it's really just like certain chemotherapy, radioactive isotopes. Certain amphetamines, ergotamines, and statins is the other one that they like really don't recommend in breastfeeding. But it's not really that many things, and yet
that's very few drugs actually.
Yeah, it's so few, and but despite that, in this like breastfeeding medicine group that I'm in, people are like it's like crazy the duration that people are told. They're like, I'm going in for like an elective outpatient cholecystectomy, and I was told to pump and dump for a week.
Whoa.
Yeah.
Wow. Okay.
Oh no, that's
it's a long
terrible.
time. And it's like I don't know where that information comes from. I don't know if it's a medical legal thing. And so then they're like, well, like it's a lot of work to pump for a week and then like not be able to feed that milk to your baby.
I mean, we let people drive like 24 or 48 hours after they've had surgery, but
absolutely.
And even like a day is like it's just crazy. Like if they're like awake and like cooking a meal for their toddler, they can like I'm pretty sure they don't have a bunch of propofol.
It is gone.
It's gone.
Yeah,
and that's
all
gone,
these medications are gone.
Yeah, so it's just really interesting that I do think it is like an issue with like the medical legal, like people are so afraid to do anything with pregnancy and breastfeeding. My partner and I always laugh at like all of the things like that it says like do not like I take vitamin D. It's like which I take extra vitamin D so that it gets into my breast milk to feed my child, and it's like ask a doctor before you take this breastfeeding. I'm like, it's vitamin D. Like I should be giving it to the baby.
Yeah. In fact, people like give their kids D drops, right?
Exactly.
In addition
to that. Yeah. So it's just crazy. I don't know why it is like that. And I mean, I know some of the driving stuff is related to that too. It's just all about this like kind of litigious thing. And, I think if we can just support, whatever the parent's decision is, that's like great. And like people do have like the few times that I've prescribed medicines to breastfeeding moms, they're super, super nervous. And I've had a few times where like they've needed, breast abscesses and things like that dealt with. And the local anesthetic, the general anesthetic is like obviously usually one of their biggest concerns. And it's really not a concern generally unless there are these very specific situations, right? And in which case, I mean, good to know, but I don't think that's like our bread and butter, right? Like our bread and butter isn't giving radioactive isotopes to breastfeeding parents.
100%.
So
I think like one thing that people don't really realize sometimes about like going to medical school or the process of going to university, or I know that you like have a master's in statistics. Before you went to medicine, is that so much of school is like learning about what resources are valid and what resources are not valid. And I think that's not something that you just learn like in elementary school and high school.
Right.
I think you kind of have to like achieve these higher levels of education to know how to evaluate like resources safely.
Yeah.
And I think that's like such a big part that fuels this, right? Because you hear all these people's anecdotal evidence or like you were talking about like mom groups. I've heard that from lots of people before. I recently had a lady come in for an elective cholecystectomy, so to take her gallbladder out. She was 4 months postpartum, and that was her first question that she asked me, like, when is it safe for me to resume breastfeeding?
Yeah.
So I told her
and like
exactly what you said.
cholecystectomy is like the one, right? Probably most common just because of all the stuff that happens with the old gall bag.
The old gall bag in pregnancy.
The old gall bag. Yeah. Especially with like, more advancing maternal age. I include myself in this as a geriatric parent. And, we're just going to see more of that
geriatric parent. Oh my gosh.
Yeah. This was like evidence that our phones are listening to us. I was talking with a girlfriend who's like my age about just wanting to start having kids, and and I already have 2 kids, and I don't think I'm that old, but, and then like literally right after the conversation, my phone, I was like scrolling Instagram and there was a message that was like, it's not too late. You can still have babies. And I was like, okay, listen, back off. But also I have kids already. I know it's not too late, but I was like, stop listening to me.
Yes. Oh my gosh. Yeah. Yes, they are always listening. That's
totally.
Okay,
and there are some good resources I was going to share too. So the main ones that I use are if you don't want to download an app, which is fair because like everything's on an app. The National Institutes of Health it's like Lactamed. It's literally just like the first part of the word lactation.
Like all the medications, right?
It has meds in there I've never heard of, never heard of. And it's nice. It tells you like if there is data on it, it will tell you that like RID dose, and then it will like has some information about like general safety if there's actually been research or if there's been like any case reports of anything bad happening. I find it a bit like wordy. Like if you really if you're doing this a lot, like if I don't know if you work in if you're doing a lot of breastfeeding type medicine and like I wouldn't say I do, but I have the app because it's just like an interest of mine. And now I'm going to forget the name of it, but it's right here. It is called, and it's free. It's free to download. And then you have to there's like different levels of things. So I think for sure if you're like, OB or like anesthesia where you're doing like a lot of sort of peripartum care, it might be interesting. It's called Infant Risk. And it is actually by a breastfeeding medicine group out of, I want to say the University of Texas, but it's somewhere in the States, but it's excellent. It's excellent to it has actually if you're OB for sure, because it talks about all the medicines, it by trimester, and then for like 0 to 3 months postpartum, 3 to 6, 6 to 9, and sort of like has a rating for the safety that's just it's a little bit more user friendly than like the Lactamed one.
Yeah.
It's just like, it's more like infographic type.
Nice.
Where you can actually just see like, it's okay, I have a patient, she's like 6 months pregnant, I want to give her like acetazolamide, and it's just right there. And then if you scroll down, we'll also give you all of that like RID dose and that kind of thing. So yeah, that one's excellent. And then honestly, like you can like Up to Date 2 has like the pregnancy and breastfeeding considerations. And that like Up to Date is just LexiComp, right? So it's in there too. Again, a little bit wordy. It's like you kind of have to dig for it, and oftentimes I think it will just say no data, which can be frustrating
for particular ones.
And you're just like, okay. And I feel like Infomed, even if there is no data, they try to, again, it's because it's what they do. They'll say, okay, but like this is the pharmacology of this drug, and this is like, even though we don't have studies specifically like testing for this drug in breast milk, like theoretically, this is what it should do. And obviously you can weigh the balance of like the risk and how badly they need this med. But yeah, like there's so many antibiotics you can use in pregnancy, so many analgesics, like it just really shouldn't be an issue. And I just think that, going through whatever you're going through shouldn't be it shouldn't affect the person's breastfeeding goals. Like I think you can still meet those, and there's ways around all of this. So I hope over the next, as people hopefully learn a little bit more about that this sort of like, you just like right now it just seems like, okay, pump and dump in some random amount of time.
Yeah.
And it's just, it's outdated. I was going to ask you guys a question. What's the, that's sort of like related on the opposite side. If you have a baby, like a breastfed baby, what's like the timeline that they use here for being MPO?
I think that's changed a little bit.
Yeah,
now,
they just like put out some new guidelines.
Yeah.
But it's 2 hours. 2 hours for breastfeeding.
Yeah, so I was reading that. This is what I asked, because I also found 2 and 4 hours, and I thought that they were like, some of the studies were saying that the gastric volumes were still a bit too high at 2 hours, and so they wanted 4. But then others were saying treat it as a clear fluid, and Like 2, like what do you do for other like
clear fluids up to 2 hours before surgery usually. And I think
and what about like say cow's milk? Would that be, that's not a clear fluid?
That is not considered.
Yeah. So that would be, what would that be, like 6 hours or 8 hours?
8, I think. Yeah.
8.
Yeah, because it's a fattier,
right?
Like essentially any sort of fatty thing.
Mm-hmm.
Yeah.
So we kind of tell people like if you can't see through the liquid, it's not considered a clear
liquid. Right.
Yeah. So apple juice or ginger ale, like these are all considered clear liquids. Tea.
Yeah.
Black coffee.
Yeah.
A lot of people can't live without black coffee before the morning of their surgery.
Right.
But they are looking at the powers
the
that
people,
be, are looking at breastfeeding. And I think, what it really has to do with is if you're concerned that this baby will aspirate when you intubate them. And by that, I mean, for those people that don't know what the term aspirate means, will fluid from the stomach come up and go into the lungs when you're trying to instrument the airway to put in a protected airway for surgery. And that's when there's extra considerations. But I think there's actually a really great study going on right now here within our department where a resident and a staff person are looking at ultrasounding abdomens.
Oh, cool.
Of children to determine NPO status. Right. Which is a really, really good study. And I think will yield a lot of great evidence about like maybe this is something that we should be doing for children.
And we in Emerge like always make fun of you guys for this whole NPO thing, right? Because we just like tubing on Big Macs all day.
Yes, and we do too.
I know. When you do emergency,
when we do emergency cases and things like that, and we always tell people that, but
ideally, and I totally get it.
People should not have any. Like,
I wouldn't want my baby to aspirate on induction if at all possible. So and actually, like I was saying, I was working in the coronary care unit, so like the critical care for the heart right now, and have had a few intubations this block, and like all of them, and a lot of them have probably arrested and had a cardiac arrest and had an aspiration event just because of that. But I'm like, man, like. Just seems like everybody aspirates, and so and they do, they get sick, they get their lungs get bad. So I totally agree. I think and certainly like my younger child is 6 months now, and he could easily go the 4 hours. It is like I'm imagining back, like if he had needed some sort of procedure as a young child, like those little guys, the gals, they eat like a lot in the beginning. It'd be hard. It'd be really hard. And like you can use a soother or something, but I do definitely feel for those parents that are trying to keep their kids unfed. Like kids like really just need
hard.
I think we've recognized that in anesthesia, that it is really difficult for parents, especially people coming from out of town or something, because their child needs surgery, and then they have to be NPO on top of all of that as well. So our department does have a few different projects going on about that, and I think the guidelines will be changing.
And I think like that sort of patient-centered stuff where you're like, okay, this person's coming in from like Tisdale, which is one of our peripheral communities, and like let's try to maybe make them the first case so that
exactly
like things like that.
That is definitely something that the anesthesia, the pediatric anesthesia group is thinking about. Yeah. And when they discuss with surgeons about planning cases, that's something that they think about a lot. Because like they really just want like the best thing. All those people that are work in medicine, we all just want the best thing for our patients. But there's like a special, more even caring group of people that do pediatrics. And they like really, really want the best for all of the little people that they take care of. So
it is good. I think a lot of that is changing and good, and it's just I think it is interesting because again, like on a sort of like small tangent, that it's like I just find the breast milk as a fluid so interesting. It's like it's got IgA in it, and it's like
it's got like big molecules,
like protein, and then like it's like at different times of the day your breast milk composition changes as your baby like gets older. It changes from this like super fatty colostrum to like a more liquidy. It's like I noticed that like the color changes because I when I'm away from my baby for work for 24 hours, I pump like all day, and like the color of the milk changes throughout the day, and it's just wild. Like it's just a crazy thing, and like just such a weird. Yeah, and so and how the body absorbs it like differently than cow's milk, which is why it's like it's not a clear fluid, but it's not like milk really, like cow's milk. Yeah. Anyway, super weird. And then, yeah, I guess that's a semi-good transition. I think the last thing we were going to talk about was like just as people in medicine and like thinking about another way we can support breastfeeding people is supporting them pumping at work if they're going back to work, or supporting, breastfeeding in ways. And you had found, and I think I had mentioned that the American Anesthesia Society had put out a statement regarding like protection of time, and they mentioned like both like clinical anesthesiologists as well as the nurse anesthetists and your like respiratory therapists and the people that help you in the OR. And like pumping technology has come a long way, and there's a lot of things like wearable pumps. And so you see like anesthesiologists like pumping through their cases. And I think that's awesome, but those pumps are still like very expensive. And so like traditional breast pumping where you're like actually like attached to a machine is still like for sure the more economical way to do it. And I think it's, again, I think we are as a society getting better at like supporting parents through new parenthood and breastfeeding goals and all of that kind of thing. But we actually in our province, we don't have anything like that. I think personally, I felt very lucky. I think we like work in a very supportive environment, and I personally have not yet had a problem to be like, hey, I have to step away from rounds for 15 minutes because I have to go pump. No pushback, no issues. As an emerge resident, it's maybe a little bit easier because we don't really round. I can just kind of stop seeing patients for 15 minutes. And a lot of like surgery colleagues, and I think anesthesia as well, have talked about like pumping between cases because usually there's a bit of like an OR turnaround. But I think getting, if you're someone who's working somewhere, and I think I've seen on, again, some like motherhood in residency and medical school groups about getting like official policies in place just so that in case, it comes up. And I think it's interesting because there is a bit of a attitude, I haven't encountered it at work, but in like talking to people outside of work who I tell them, or they see me nursing and they're like, oh, how are you nursing? Because you're working.
Yeah.
And I'm like, well, I pump. And they're like, oh, well, doesn't that take away like time from your job and stuff? And I'm like, maybe a little bit, but if someone had like an ostomy bag and had to go change their bag, like you would never say like, doesn't that time take away from time from work? And when you are breastfeeding, it is like a something for you and your child, but also if I decided today I was done, like I can't do it anymore, I can't just stop. Like I would be in a significant pain. I would certainly develop mastitis. Yeah. So it's like you have, if you are choosing to breastfeed, like you actually have to empty your breast. Like it's just not like you can't be like, oh, I'm rounding, I'm just gonna not. and there's been a few times where I have had sick patients and I like push it like 20 or 30 minutes and it's been okay. But like then it's like, okay, now I gotta go. Like I have to pump now. So I think just like, not that I want to medicalize it, but like this is something that's like, it's not really like a want. Maybe the choice to breastfeed is a want, but like if someone's making that choice and we're going to support them, then we have to recognize that at that point, now it's a need. Now it's like, I have to do this. Like, so I think if we just have policies in place, and we have great pregnancy related and parenting related protections in place here in Saskatchewan, but I think we can just add this like one extra thing. And then I feel like we'll just be committing for a full circle.
Yeah. Yeah. I think that, I think it's great that things have kind of shifted, like you were saying, and that things are, I think, moving towards like I think things are very supportive now. Yeah. But I just wanted to say that probably one of our best residents in our program, the most diligent, best resident, has 3 small children. Yeah. And she had a child in residency. Yeah. And pumped every day. Yeah. And she studies just as much as everybody else, if not more so. Yeah. And it is always on top of things, like way more than anybody else.
If anything, I feel like people, like, honestly, I know this, I'm not like trying to pump my tires in any way, because I truly believe that like everybody just adjusts to the situation. Like if you had told me like at the beginning of residency that I would be like waking up 2 hours before my shifts to like feed a baby, get a toddler ready for daycare, driving them to the other side of the city, dropping them off at daycare. Like, and I have a great, wonderful, supportive partner, but like there's still days where it's like all on me. And then like working like, 8 to 10 hours and then coming home. And then before I can do anything for myself, I have to like pick the kids up, make them like a nutritious dinner, oh my God.
Yeah, you
can't just like be like, yeah.
Eat some cereal.
Exactly. Yeah. And then like get them to bed. And then I would have said you were nuts because like I love sleep more than like 98% of the people in the world. I'm like not a morning person at all.
Yeah.
And it was like, it's funny because I'm usually quite early to work now. And I've gotten someone like, how are you so early? And I'm like, I have kids, man. Like they wake you up early. And so like, I'm just up early now. Like this is just my life. And I actually think I'm more studious now because like when you have kids, if I want to go out at night, I have to pay a babysitter. And like, it's not like we're like raking it in residency. So I'm like trapped in my house from 7 p.m. onwards every night. So I'm like, well, might as well read Rosen's Guide to Emergency Medicine, right?
Gotta get through that textbook somehow.
Yeah. So it is funny because like even this week they're like, "You're here so early." I'm like, my son was up at 5. So
yeah.
What else am I
I
gonna
think
do?
parents become such good time managers.
Yeah.
Do you think that?
Yeah. Oh,
that's what I've really noticed about my colleagues that have children is that they just really know how to like what to prioritize and how to prioritize their time. And they're like, I only have an hour at night unattended to like really know this topic well. And they just do it. And I'm honestly always so impressed with them.
And I was not that person in any way before I had kids. So, I mean, I'm like a little bit, I think I have like coping strategy for my own disorganized brain. And so I use like a lot of spreadsheets and like I said, I have a master's in stats. So I'm like a little bit that way with things, but certainly like the time piece of it has, it's like for sure. And I think people in medicine in general are a little bit disorganized sometimes. And so like having the extra like, I have to keep this life alive. It just like really...
Yeah, you just really focus your
focus
attention.
in. Yeah, for sure. So it's been good. It's like it's a fun adventure, and I'll be excited to welcome you into the
parent clan.
Looking forward to it.
Yeah, it'll be so fun.
Yeah, honestly, always so impressed. Like you guys are such great physicians. Such great people. And then I like, when I see your children, I'm like, wow, these are like really good children.
Oh yeah. That's because you haven't met my toddler yet.
No, but like even when, toddlers are just kind of crazy and stuff and they're just exploring the world and like having a great time and like I think like are the most joyful creatures.
Yeah. Oh, totally.
Most joyful and filled with rage. It's hard to say.
Filled with rage. Yeah, totally.
But I'm always just so impressed. I'm like, oh my God, you're killing it at residency. And then you're like creating these like actual amazing human lives.
And like, that's what I tell my partner all the time. I'm like, you provided one cell and then I grew it. And then like now I feed them with my body. Like, I'm like amazing.
Which is true. It's like a really amazing process.
And I should go back and say, because feeding your baby in any way is amazing.
Is amazing.
Yes, feeding with whatever you can is also great. So
just like raising children in general.
Yeah.
And like dedicating time to your children is amazing.
Totally.
Yeah.
That's like pretty much all I had to say about breast milk and
well, I learned a lot.
But
did you learn a lot?
Session.
Okay.
I did. And
amazing.
Hopefully other people do too.
This is very enlightening. Thanks.
Yeah, good. We're just really here to prepare you.
For the time to come. And because of this patient I had recently, like took more of a deep dive into it. And it was really great because when we had the conversation, I felt like I could say with 100% certainty, like it is absolutely safe for you to breastfeed. You should breastfeed right away. Like you said, as soon as you're ready to hold your baby and you feel awake enough to do so, you should breastfeed.
Yeah, totally. And there is like a big, you get a endorphin rush. So I think it's nice. It's cuddly fun. You just had surgery.
And that's probably a little bit of good analgesia because, serotonin
is it an analgesia?
Is involved in the pain pathway.
Yeah. This is why I didn't do an anesthesia residency. It's like too many
of
those drawings with like the arrows.
Feedback.
Feedback loops.
Yeah,
that would have been tough.
I got asked about Krebs cycle not that long ago. That took me back. Took me back to 2008.
Nice. When you were in an undergrad.
When I was in an undergrad learning about Krebs cycle.
Yeah.
Yeah.
Anesthesiologists do ask the best like questions that are just like so esoteric and random. But
I love
it's like
it.
Yeah, it's good.
It's good. It's not for everybody.
It's not for everybody.
But it's good for me.
It's good for you.
Yeah.
Great.
Yeah, awesome. Well, thank you so much again for joining us. Very, very much appreciate it. And I would just echo like the resources that you mentioned throughout the podcast. Like definitely check those out.
And Infant Risk is the app. Yeah. both awesome.
Yeah, and if you want to take the deep dive, the statement on resuming breastfeeding after anesthesia is really great, and it has a table in it that includes the RID values that we talked about for basically all anesthetic drugs that we use.
Sweet.
So if you're ever curious and want to make sure that it's, the less than 10% that we talked about for safety, then you can just double check.
Awesome. Thanks, guys.
Very cool. Thanks,
all right.
Lauren.
Yeah,
awesome.
thanks.
Thank you so much for joining us.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.